introduce now Dr. Brendan Saloner. He's an associate professor in the Department of Health Policy and Management at Johns Hopkins Bloomberg School of Public Health. His research focuses on access and quality of care for people with substance use disorders. Professor Saloner has investigated the impact of federal and state policies regarding insurance coverage and benefit design related to substance use disorders on access to care and outcomes related to treatment. He is funded primarily by NIDA, National Institute on Drug Abuse, the U.S. Department of Justice, and Arnold Ventures. He holds a doctorate in health policy from Harvard University and completed the Robert Wood Johnson Health and Society Scholars Program at the University of Pennsylvania. And in 2019, Professor Saloner received the Alice S. Hirsch Emerging Investigator Award from Academy Health. So, welcome.
Thank you so much. It's really great to be here today. So I'm going to talk about public health. Public health is really about the science of thinking about population-level interventions. As I sat here hearing the really compelling testimony from the other folks here, I think one of the important through lines of today's presentation is just the importance of confronting and thinking about the stigma against the disease of addiction. And actually, although it's not in my presentation, I would really encourage us to think about reducing stigma as an important public health strategy. We can't get to good solutions until we start talking about addiction and dependence in ways that are respectful and fully incorporate the variety of different life experiences. So I don't have any financial conflicts of interest to disclose. I just want to mention that the statements that I make don't represent those of my funders or the Johns Hopkins University. And so in my presentation, I'm going to be channeling a couple of pieces of work that I've been involved in, just to plug them. One shown on the left is an article that came out in the journal Public Health Reports called "A Public Health Strategy for the Opioid Crisis." And here we sort of lay out the building blocks to what we think are an evidence-based set of interventions that taken together would have a very positive impact on reducing our national burden of addiction and overdose. And then the second is a report that just came out, was convened by the Association for Schools and Programs of Public Health, called Bringing Science to Bear on Opioids. And both of these pieces are free and available on the web. So Dr. Valkow alluded to the three waves of the opioid crisis. And just to sort of set up the epidemiology of the moment that we're in, we know that going back to the late 1990s, there was a rise in overdose deaths that could be linked to prescription opioids. That trend leveled off around around 2010, and we saw that spectacular and very disturbing rise in deaths linked to heroin. That's the yellowy-orange curve shown on the graph. And then most recently, we've had the rise of deaths related to synthetic opioids, and in particular fentanyl. And I would argue that we're actually in the midst of a fourth wave, which is a polysubstance crisis, and I can talk a little bit more about that. So these data are well known. Maybe some of you have already seen the chart that I just showed you, which was produced by the CDC. I think there's some other features of our overdose epidemic that are less well discussed and less well understood. One of which is that the overdose epidemic, although it's typically talked about as something that disproportionately affects white Americans, is most rapidly actually rising among minority populations, particularly African Americans and Native Americans. The second, as I mentioned a moment ago, is that we are in the midst of a polysubstance crisis. So overdose mortality no longer is uniquely confined to opioids. Many people are also dying from cocaine and methamphetamine-related overdose, sometimes involving fentanyl, sometimes not. So I think that we need to understand that even as we as a country try to get our arms around this massive and unprecedented opioid crisis, that this is really a shape-shifting crisis that's going to morph into a crisis that affects other substance abuse. And there's a lot of things that actually we as researchers and epidemiologists don't really understand. one of which is the changing nature of the drug supply that is available to people who are either legitimately prescribed pain medications or people who are sourcing drugs in the illicit market. Unfortunately, we still don't know a lot about rates of initiation and transition across types of use. We do have national survey data that give us a glimpse into this, but it's a very difficult phenomenon to track. And finally, and I think this is really important to what I'm going to say in the next few slides, we don't fully understand how many Americans need help right now and how many of them are actually able to access evidence-based treatments and harm reduction services. I'll talk about what I mean by harm reduction services. So these are what I think of as the building blocks of a public health strategy. First of all, I would say that a public health strategy is quintessentially defined by a focus on risk reduction, meaning that no matter who you're looking at in the population, there are strategies that we can pursue to try to help people who are either using drugs to use more safely or to help people who are chronic pain patients to develop an effective pain management plan, or to focus on the science of prevention, which I know is going to be in the next presentation. Not ideology. It's important for us to get out of our bunkered kind of mentality about, for example, the idea that when we treat addiction with medication that we're substituting one drug for another. The second is that we need to have a strategy that's driven by data. I think that sounds obvious, but in part I feel like many times this debate is being done in a way where there's just not a lot of evidence being brought to bear, so we need to have good data to make good decisions. We need to be able to have a strategy that encompasses not only individual determinants, but also structures and policies, and to think about how those things interact, because there are synergies. We need to tailor to different populations, and we need to have a long-term and intergenerational orientation. And that may sound like a throwaway point, but I actually feel like nationally we are in such a acute crisis, so much trying to put out a fire that's in front of us that we're not thinking about this opioid crisis as something that's going to be with us. Well into the next generation, many children are affected by this issue. So the first strategy that I want to just take a moment to talk about is increasing access to medication treatment. So the medications that treat opioid use disorder, and I'm especially interested in the opioid agonists and the partial agonist buprenorphine, have been shown both in clinical trials and in population studies to cut overdose risk in more than half. So it should be a no-brainer that we should have wide, scaled-up access to these medications. In fact, what we know is that many patients don't receive these medications, and if they do, their quality of care is often poor. If you look at a map of where treatment providers are located, there are many communities in our country that don't have any access to either an opioid treatment program where they could get methadone, or to a place where they could visit an office-based prescriber of buprenorphine. The stigma against medications is pervasive, so this gets to sort of the heart of today's topic, that these medications, while they may continue dependence in a physiological sense on opioids, they do not substitute one addiction for another. Being a patient using these medications is not a form of addiction. These are data from a population cohort study in Massachusetts, and I think that they illustrate very vividly the importance of getting patients on methadone maintenance, shown with the triangular markings of buprenorphine, compared to patients who receive no medications for opioid use disorder. You can see that, and this is a population of patients who non-fatally overdose, so a very high-risk population. Tracking them in the 12 months from that event, you can see that their risk of dying is just much lower in that time period. So these medications really work, and they have a sustained impact that is life-saving. The next bucket that I want to talk about, and I think that this is not as foregrounded in our conversation as it should be, is scaling up harm reduction programs. What is harm reduction? Well, the way I think about it is it's all the services that we provide to people who use drugs to increase their safety. So naloxone, or sometimes known as Narcan, is a medication that can be provided to patients to reverse the onset of an overdose if they're experiencing one. But there are many other harm reduction tools: sterile syringes through syringe service programs, fentanyl test strips so that patients or individuals using drugs know if they acquire drugs whether there's any fentanyl present in their drugs. These are all tools that are out there but are not widely available to people who use drugs. And I think at their best, harm reduction programs are a comprehensive healthcare service on-ramp and a low barrier way to start treatment. So sometimes we talk about this as if there's two possible ways somebody's life could go. They could either get treated or they could get harm reduction. And I actually would contend that the two things work very well together. And as I said, harm reduction programs are not adequately scaled up in many systems. There are many places where these kinds of resources are just not available to patients. So these are recent data from the CDC's Morbidity and Mortality Weekly Report, and it just shows you on a map the density of naloxone prescriptions. And this should really be the standard of care for patients who have markers of high overdose risk, either patients who use opioids at high doses or people who, for various reasons, might be at risk of overdosing from illicit drugs. The other place where I think our public health strategies are really falling down is in the linkages across systems. People who overdose come into contact not just with healthcare providers, but with emergency medical services. They come into contact with hospitals, with criminal justice and social services. And yet, if you think about the resources that we have as a country to tackle this, the funding is often siloed, and it's difficult to coordinate those resources across agencies, and those agencies often have their own cultures. I work a lot in the criminal justice space, and I can see that the way that this issue is talked about by police and in prisons is different than the way medical providers talk about it. So we need to have a common language to work together. There are ways to overcome these linkage problems, and one of the things that I would call your attention to is the use of peer counselors who can help patients to sort of navigate their way across systems that they may encounter. So this is hard to read. This is from a study that our research team published in 2019, and it just shows you, this is a population study in Maryland, and it shows you in different segments of the population what the overdose risk is. And the main thing that I want to draw your attention to is that our study team is able to document something that is well known, which is that people who come into contact with the criminal justice system have much higher risk of overdose than the general population, like by a factor of more than 3 or 4. Something else that we documented that I think was a little bit new in this study is that actually people who have come into contact with both hospitals and the criminal justice system have much higher overdose risk than either populations who come into contact with just one of those systems. So it's the fact that people are coming into contact with these systems, there's touch points and opportunities to change their trajectories. So what's the course forward? I think this opioid crisis is going to be with us for a very long time. We can get the overdose numbers down tomorrow, I hope we do, but at the same time there's many other related epidemics. There's an epidemic we now have related to HIV and HCV. There's a mental health crisis that is going along with this. There's many syndemics to the opioid epidemic. So we need that intergenerational approach, and we need to start thinking with this long-term orientation. And I would say, if I was speaking to the Congress, we need to have predictable funding that helps us to adjust our strategy over the long period of time, not dribs and drabs that come out over 1 or 2 year installments. We also need to build up our basic structure, our capacity in data tracking and public health infrastructure. This is really critical. We don't have key data to guide our approach. And with that, I'll stop and say thank you.